Euro. Today we're going to think about valves. Going to start like usual by looking at the things that are in the core curriculum. I know that some of these have been covered in your ELM course, ELM 2 I believe it was, but we're going to look at them from a slightly different angle, and then we're also going to be covering some new diseases. So in your previous learning, to remind you, these were the objectives from ELM. You particularly concentrated on aging in valves, rheumatic fever, both acute and chronic, infective endocarditis, and abnormal valve function and its effect on physiology. So remember these slides, here we go. So remember the difference between stenosis, regurgitation, and both, and their relationship to volume overload with regurgitation and pressure overload with stenosis. We'll give some examples of that soon. And you've also learned about valve pathology and its complications, hypertrophy of the left ventricle, dilation of the left ventricle with volume overload, for example, or left atrium with mitral regurgitation, and then the secondary effects of that, particularly atrial fibrillation. If you want a good overview of the diseases of valves, we can vindicate them. So congenital, the malformed valve, usually the bicuspid valve, which has accelerated degeneration. The degenerative changes, calcific aortic stenosis and mitral valve prolapse. The immune-related diseases, of course, rheumatic fever, which affects the mitral valve mostly, but also the aortic valve, infective endocarditis, and then in other, the big one is ischemic heart disease, which can lead to mitral regurgitation because of the abnormalities in the papillary muscle. I think these ones here aren't particularly worth thinking about. All right, let's go first to the degenerative valve diseases. Bicuspid aortic valve is common, so 1 to 2% of the population, and it's due to the fusion of two commissures. And this abnormal anatomy means it has increased wear and tear. So the changes in it are very similar to those in ordinary calcific aortic stenosis. It's just that they can happen at an earlier age and more frequently. Here we go. Here's a bicuspid valve. It's looking all rocky and calcific because of the advanced calcific aortic stenosis on it. And here is a tricuspid valve with similar changes. So these changes will happen earlier and more frequently in bicuspid valves. All right, so here's an MCQ. A newborn child is diagnosed with a bicuspid aortic valve. Which of the following statements is true? Is he at risk of early myocardial infarction? Because of the nodular calcification, that can include coronary arteries. The answer is no. The valve calcifications are on the tips and do not include the ostia. Would his sister have a 50% chance of having a bicuspid valve? No, because it's not autosomal dominantly inherited. It's a developmental disorder that occurs sporadically in the population at 1 in 100, not 1 in 1,000. But yes, he does have a 1 in 3 chance of developing significant stenosis requiring aortic valve replacement. Let's have a little think about why the changes happen in the valve. So it's a bit like atherosclerosis. It's not atherosclerosis, it's a bit like it. So it's a bit like it because there are initiating factors. Okay, so we've got damaged endothelium here, increased damage in bicuspid valves, particularly because of things like shear stress, which results in inflammatory cells and fat moving into the valve. And that is similar to the start of atherosclerosis. But then what happens is that all the cytokines that are activated, they change fibroblasts into osteoblasts-like cells, which results in calcification and the formation of these large nodules, which can in some cases actually develop true bone in them. What happens when aortic stenosis occurs? So what happens is the left ventricle goes into a high pressure system and it hypertrophies. So there's cardiac enlargement, as we can see here. But also on the ECG, we get very big S spikes because the QRS complex is increased in size because of the volume of the heart muscle. Okay, so this is another sign of cardiac hypertrophy due to aortic stenosis. Here we are again. Aortic stenosis, pressure overload leads to concentric hypertrophy of the left ventricle. This is in contrast to aortic regurgitation, which is a volume overload. Remember, regurgitation leads to volume overload. The heart becomes big, but it has a thin wall. Now, eventually, left ventricular hypertrophy, as we will discuss in the myocardium set of slides, can lead to ischemia here in the wall and damage, which eventually does lead to decompensation and this secondary dysfunction. Okay, so I know that you know this already, but just to remind you, on the left side, the pressure, if the left side isn't working, venous return from the lungs is impaired through the atria, leading to pulmonary congestion and pressure, but also supply of body organs is abnormal, so low organ perfusion and hypoxia. And in aortic stenosis, this in particular is demonstrated by syncope. Okay, so in people who have aortic stenosis, they tend to develop syncope. The pressure is okay, but just the volume that is ejected, or the volume that can pass through the stenotic valve, is impaired, and so people get syncope. In contrast to the right side heart failure, so right-sided heart failure is due to abnormal venous return from body organs, and failure leads to congestion of body organs, knowing that the most common cause of right-sided heart failure is in fact left-sided heart failure. Okay, so failure happens because of increased pulmonary vascular pressure, for example, from chronic lung disease, from left heart failure, and then it causes all these things, congestion of body organs. I've written this down in a series of notes that you can study. Here we go. I'm not going to read them out to you, but you can stop the video, have a look. I thought there was some quite useful mnemonics here. You'll cover all this in your medicine run, I'm sure. All right, different valve, mitral valve. So mitral valve prolapse, again, 1 to 3% of the population, incidental and asymptomatic until, of course, it decompensates and causes left atrial overload. It is very occasionally associated with Marfan syndrome, but mostly it is just sporadic. Here the valve becomes thick and weak because it fills with this myxoid material. So what is myxoid material? Think of it as a bit like snot. It's full of mucopolysaccharides. What happens when the valve becomes weak? Well, it billows back into the left atrium. Here is a diagram. So normally the valve closes and the edges meet, but if it's loose and floppy and billowing back and has long chordae tendineae, then of course the edges don't meet effectively, and a jet of blood goes back and expands the left atrium there. What causes mitral regurgitation? Various things. So commonly, as we've said, due to mitral valve degenerative disease here, rheumatic fever, which we'll talk about in a little while, muscle damage, papillary muscle damage from ischemic heart disease, or left ventricular dilation, which just like moves the valve opening out. So it just expands it, so it's no longer competent. And here we are with rheumatic fever. I know that you've learned about rheumatic fever. Rheumatic fever is a great type disease because it brings together cardiac function and immunology and social aspects of medicine and genetics and microbiology. And so it's often used extensively as a case history in your undergraduate teaching. But let's look at a few pathology points again. All right, I'm sure that you know that it's caused by group A stress because of cross-reactivity to group A antigens, strep antigens with self-antigens in the heart and other places. Okay, gives a pancarditis, so all three layers of the heart and the valves are affected. It's due to a type 2 hypersensitivity, so antibodies form, and then the antibodies are deposited in tissue, leading to complement activation, and then off we go. There's even more cytokines and there's even more white cells. But in addition, it also has T-cell mediated inflammation, type 4 hypersensitivity. Okay, so once those T cells get there, they just keep going and recruit and activate macrophages. Okay, so there's acute and there's chronic rheumatic heart disease. The chronic rheumatic heart disease is caused by fibrosis in these valves and permanent valve deformities. Often people talk about a fish mouth deformity because the edges of the valves kind of stick together, trying to do a fish mouth here, like, and the valve just like closes up a bit like that. Okay, 90% of rheumatic fever has mitral valve. Sorry, 90% of valve involvement in rheumatic fever is mitral. 25% can also have aortic valve. And all three things can lead, are affected, the endocardium, myocardium, and pericardium, as well as the valves. The acute myocarditis can rarely lead to death, but often just heals up and isn't as badly affected as the valves. So let's think about the valves. Okay, so the valves get these little tiny vegetations along the edge, small, 1 to 2 millimeters, sterile. Okay, so this is where people get confused. In rheumatic fever, the vegetations are sterile. So you can get secondary infectious endocarditis in rheumatic fever, but the primary vegetations in rheumatic fever are sterile and they don't embolize. Okay, so this is what the pericarditis looks like. It's again a bit like the bread and butter shaggy fibrin-rich pericarditis. Okay, and rheumatic myocarditis are little areas of inflammation called Aschoff bodies. You can also find them in the valves, by the way, with central necrosis surrounded by lymphocytes, because by the time we get here, it's a type 4 immune reaction. The type 2 initiates it and the type 4 continues it. Okay, so in summary, here we go. In chronic rheumatic heart disease, we have thick fibrosed leaflets with buttonhole or fish mouth appearances, thick chordae tendineae, and valve dysfunction. So in the valve dysfunction, you can get stenosis and regurgitation because the valve kind of sticks in a half open, half closed position. All right. And then endocarditis is the common complication. So the other common complication, of course, if you have abnormal valves, is going to be, yes, heart failure. Okay, so if the mitral valve or the aortic valve isn't working, it can lead to either dilated or hypertrophic changes in the left ventricle and cause heart failure, left heart failure, then right heart failure. So a common cause of valve replacement in people in their 30s is due to rheumatic fever because they start to develop heart failure. Carrying on. All right, so here we go. I've made you some notes too here to reflect rheumatic fever. Okay, key concepts again. I'm just going to keep emphasizing this because I know you might be a bit bored of rheumatic fever, but it is really important. It's a cross reaction, type 2 immune cross reaction to cardiac antigens by antibodies formed after group A strep. It affects 3 parts of the heart, the valves, the myocardium, pericardium, endocardium. That's 4, should have said 4. Inflammation heals by scarring, leading to rheumatic heart disease with stenosis and regurgitation. It is a pancarditis, yep. And the endocarditis, which is the bit that affects the valves, leads to these little tiny nodules on the valve edge, and the valves become swollen, red, inflamed, and that leads to fibrosis. Here's a real picture of what it looks like. All right, and then the scarring leads to fish mouth appearance with thick chordae and mitral stenosis and regurgitation. Here's the fish mouth and the joined up sides, okay, and also affects the aortic valve. Here we go. So this leads to aortic stenosis and regurgitation. Here are some MCQs. All right, Mark is 30 with a heart murmur. It's a late systolic murmur, heard loudest in the 5th intercostal space, which is typical of a mitral valve murmur. So he has a long arm span and it's tall, thin build. So he's got a mitral valve murmur and kind of a hint that he might have Marfan syndrome. It's not really old enough for normal mitral valve prolapse, because it happens to people in their 60s and 70s. So what would we expect to see on the valve? Vegetations? No, because this is a description of the vegetations in infective endocarditis. Voluminous valve cusps and elongated chordae tendineae? No, this is a myxoid degeneration of the valve. Oh, sorry. This is myxoid degeneration of the valve, which you can get in Marfan syndrome. So sorry, this is the correct answer. Yep. So Marfan syndrome does have an appearance like sporadic myxoid degeneration. Fibrosis and calcification? No, this is typical of aortic sclerotic calcification. This description here, thickened valve fused commissures, is rheumatic fever, and friable vegetations along the line of closure is acute rheumatic fever. So the answer is this. In Marfan syndrome, you get appearances similar to that in sporadic myxoid degeneration of the valve. All right, a young girl is having an acute attack of rheumatic fever. She has Aschoff bodies in her, and the answer is everywhere. All 3 areas are affected. Here we go. Mike is 12. He has typical features of rheumatic fever. Okay, so what skin changes would we see in the diagnosis? Well, if we go back here to our little crib notes. Okay, what do we get? We get subcutaneous nodules. So subcutaneous nodules is a feature of rheumatic fever, particularly over the joints. All these things are due to emboli, right? That are much more commonly seen in infective endocarditis, and petechial hemorrhages is a sign of vasculitis for things like meningococcal disease. What have we got here? So we've got a 12-year-old. He's had, fever, palpitations, and sore joints. So you're thinking, is this going to be rheumatic fever? But he has tachycardia. So tachycardia, probably if he's got rheumatic fever, means that his heart is being so badly affected that essentially the myocardium isn't able to contract well enough. So it's compensating by speeding up. Okay, a pericardial rub. Yes, pericarditis goes with rheumatic fever. and subcutaneous nodules over his joints. And then the clinching thing, he's had a throat infection 3 weeks ago. So he has acute cardiac decompensation due to rheumatic fever. What's the best thing to do to him? Well, no, do not send him home with paracetamol or non-steroidals. It's no good taking a throat swab because the infection has gone away. Same with a rapid strep antigen test, not useful at this point. This child needs to be admitted to see a cardiologist. Okay, and then we have another one. Right, so Michaela has developed a heart murmur following strep throat 2 weeks ago. What myocardial change would we see? There's only one answer that has a keyword, and the answer is Aschoff bodies, which are the little nodules that you get in the myocardium and other sites with rheumatic fever. Not amyloidosis. This happens to old people and is an infiltration of the muscle, leading to restrictive pericarditis, not myocardial scarring. This is due to MI usually. Giant cell arteritis, no, this is a disease that happens in old people that it inflames the temporal arteries most often. It's a type 4 immune reaction, but we don't understand what triggers it. And of course, a myocardial neutrophilic inflammatory infiltrate would happen after an MI. Okay, so that was your quick revision of rheumatic fever. Now we're going to go to a quick revision of infective endocarditis. These are the big ideas. Right. Low-grade organisms such as strep viridans lead to subacute endocarditis with large vegetations. Virulent organisms such as staph lead to destruction of the valve, like abscesses around the valve ring type destruction. And lots of complications can arise from the embolism of vegetations. Here's a picture of them. Notice how big they are. They are absolutely giant vegetations compared to the tiny ones that you see in rheumatic fever. And these vegetations are unstable. You can see one here in histology. This is the valve here. This is the papillary muscle. And look, we've got this giant vegetation that's just got a thin kind of stalk. So it can break off and travel. What is this vegetation made of? It's made of a central core of bacteria, which is covered over by fibrin, which incidentally hides the bacteria from antibiotics, which is why people with infective endocarditis have to take the antibiotics for such a long time. Okay, this breaks off. Where can it go to? It often goes to high flow areas like the brain and the kidneys, where it can form a wedge-shaped infarct and an abscess in the spleen, for example. And it can break off and cause strokes. So what other things can we see? Splinter hemorrhages. So here we go. These are hemorrhages in the nail bed that look like splinters. Other causes, of course, of splinter hemorrhages occur, particularly hitting your fingers with a hammer or other injury. An abscess, here's a splenic abscess. So this is not wedge shaped. This is just, this will have pus in the middle. And then around the outside, we've got probably lots of fibrin, maybe a bit of granulation tissue. This spleen's doing particularly badly. We've got several other things happening here for forming abscesses. Okay, Osler's nodes and Janeway lesions. So here we go, and Roth spots. So all these are names for little embolic phenomenon. Okay, so these are Janeway lesions. Here we go. These are Roth spot. Sorry, these are Osler's nodes. The fingers here, these are small, painful, and flat. These are large and lumpy. They do actually look a bit like the skin's had some necrosis there. And in their retina, you can see these things called Roth spots. So they're all clinical features of cardiac emboli. All right, let's have a look at Francine, aged 52, has infective endocarditis with an underlying condition that makes this much more likely. For example, rheumatic fever. though, the most underlying cause that makes it the most likely is a prosthetic valve. They do tend to get infective endocarditis on them. Okay. Oh, I've just given you the answer to the question. Okay. Which of the following conditions is associated with the highest risk of infective endocarditis? The answer is prosthetic heart valve. Okay. So all these things can have an increased risk of infective endocarditis, but prosthetic heart valve is the most common. Right. Cadence is 27 and has fever, rigors, malaise. She has rheumatic heart disease. So when people with rheumatic heart disease come in with fever or a new murmur, top of the list is going to be infective endocarditis. 39 degrees, blood pressure's normal, heart rate's up. An untreated dental abscess was seen in her mouth. Well, we know where the infection is coming from, and dental abscesses are a prime candidate. All right, here we go. The blood culture grew Staph aureus. So we know that this is not going to be a gentle, big vegetation strep viridans infection. This is going to be the pus maker, the destructive Staph aureus. Let's have a look here. So is she going to have small vegetations on the valve cuffs and endocardium? No, this is rheumatic fever. Large, bulky vegetations? No, this is subacute endocarditis caused by low-grade organisms such as strep viridans. Stenosis of the mitral valve? Well, she might do because she's had rheumatic fever, yeah, but that isn't the cause of what her problem is at the moment. What she's actually going to have is destructive necrosis of the valve ring. This is just a red herring. She probably doesn't have a large VSD because it would have been noticed. So while these two are potentially right, this one is the most right, which is what you will often be asked for in your MCQs. All right, key idea, vegetations. We've learned about two kinds of vegetations so far. We've learned about rheumatic fever vegetations, and we've learned about infective endocarditis, but there are two other states of vegetation that you need to know about. The first is this thing, the non-bacterial thrombotic endocarditis, all right? So it happens in hypercoagulable states, such as in malignancy, all right? Anything that makes the blood clot extra, and you get these small sterile vegetations on the valve leaflets. And you also get them in SLE, all right, where you get small sterile vegetations, this time on both sides of the valve leaflets. So here's a weird diagram comparing them, right? Rheumatic fever, valve edge, lots of little vegetations. So subacute infective endocarditis, big vegetations. Non-thrombotic bacterial endocarditis, medium-sized vegetations spread in discrete patches. And in SLE, you get the thing called Liebman-Sachs endocarditis, where you get vegetations on both sides of the valves. How might this be addressed in an MCQ? Here's Lauren. She has general tiredness, achy joints, a cough, feels short of breath when she breathes in deeply. But she's got characteristically a rash on either side of her nose. So she's got the malar rash of SLE. We will be doing SLE later in the course. So the doctor suspects she might have endocarditis, but it will be SLE related endocarditis. So what has she got? The answer is, let's have a look. Medium-sized sterile vegetations on both sides of the valves is the correct answer. Not this one. This is the non-thrombotic endocarditis one. Sorry, it's the non-bacterial thrombotic endocarditis. This one is rheumatic fever. This one is, of course, infectious endocarditis, and she doesn't have normal valves, probably. Okay. And that brings us to the end. That was a very quick revision of valve pathology for you. Thank you and goodbye. Kia ora.